Thank you, sir. Good afternoon, everybody. So I will be talking on the surgeries on the lateral canthus. As we all know, the main culprit at the lateral canthus is the lid laxity is there, and there are different procedures and procedures are available. So I will be elaborating the minimal invasive surgery at the lateral canthus. As we all know, the anatomy of lateral canthus, that the fibrous, it is a fibrous structure that arises from the upper and the lower pretarsal oculi, and it inserts on the lateral orbital margin slightly anterior and posterior to the lateral orbital margin, which is lateral orbital tubercle, if you see the diagram on the right side. So mainly the thing is, the problem is the horizontal laxity, dehiscence or disinsertion of the retractor, which leads to malposition of the lid margin. So how to evaluate? So you can do three tests like distraction of test. You move laterally to see the punctal position in relation to limbus, or snapback test. You take away the lid inferiorly and see how quickly, how fast it comes and opposed to the globe or not, whether punctum is visible or punctum is not visible. In this way, the different classifications are there. The third is the pinch test. You pinch then see the laxity, whether you are able to pinch the lid of tarsus or not. So this is the basically grading for assessment of lid laxity given in the books. I'm not going into the detail. So as we all know, that the aging is a progressive. So no surgery is designed to correct aging changes that can be completely corrected. So I am showing three procedures: lateral tarsal strip, then suture technique, and ligament plication, which is canthopexy also. You do a lateral canthotomy incision, it was not recorded by chance, and do the undermining and separate the orbicularis skin complex from the tarsal plate. Do the cantholysis to free the lid margin. I am tackling the only lower lid right now. So retract the lid, see the how much, estimate the how much amount of lid has to be excised. RF cautery is the best tool for this with cutting and coagulation. Cut away and separate the lid skin complex and make the cut the tarsal in the shape of tongue. And you have to pass the suture in such a way from the slightly interior from the lateral tubercle from the lateral margin, and double arm suture is passed. Even you can pass double knot at the margin, but there is a good tissue is available, and take a very good bite so that it should not retract, it should not cut through, and tight the suture in such a way that there should not be over tightening and there should not be laxity also remaining. So the suture is tight, and extra part of the lid, this lateral canthal tendon is closed, and the next step is very important, that you have to form the lateral canthus. So 6O vical suture is used, and 6O proline suture is used for fixation of the LTS. Now lid margin is created, and a very sharp lateral canthus is formed, and you have to close this incision into two layers: first orbicularis complex and then skin. It's a very simple procedure, but the only thing is that good hemostasis and selection of the case is very important. Now these are few examples with the spastic entropy and lid laxity. So the LTS was done. This is a grade 1 where the only punctum was there, but lid laxity was quite lid laxity. So these are few cases of post. But if you see this case, there is a lot of laxity, and there is shelving of the grade 4 ectropion is there. So in such cases, you may have to combine two procedures like LTS and Kunz-Zimnowski, which you have to remove the pentagon of the skin of the lower lid. Now this is the minimally invasive suture technique. Only canthotomy is done. Very small skin incision is basically given. Not canthotomy is done, because we are not touching the canthus. Canthus as it is. This is now a very good bite from the periosteum is taken, so that it should not cut through, and assessment already been done preoperatively. How much laxity is there, how much we have to tight the skin. So this is a 6O proline suture is passed in such a way that it comes through the away from the this area, and good bite again is taken from the periosteum, and it is tightened. The only thing is slight bunching. You can see it appears temporarily on the table, but it disappears later on, and you close the skin and orbicularis complex. So this is a very quick 5 minutes procedure. So this is done. This is a patient of operated mandibular carcinoma, and patient developed facial nerve palsy, and the patient was bedridden and was not able to come. So I have gone to his house and done on bedside. So this suture technique is very excellent, very dramatic results it gives. Now this is the patient with canthal laxity and plication of canthopexy was done, given skin incision and double arm vertical mattress was done and fixed on the lateral canthus. I don't have the movie for it. Now there are different conditions also, like uh, they may mimic like ectropin or entropin, but they have different remedies available, like allergic and dermatitis they cause ectropion. Or so basically we have to require to treat the underlying pathology. Don't rush or don't confuse with for beginners. So in conclusion, canthal tightening technique is very effective and minimally invasive procedure. A proper examination evaluation is very important to implement a correct procedure. Rule out any other inciting factor like allergic dermatitis. And the last and the most important, the clinical photograph is very important pre and post operative. Make a practice to take all clinical photographs so that you can ensure the patient that what are the results post operatively. Thank you very much.
Thank you so much, sir. Sir, can you please throw some light on how will you go for lateral canthal tendon repair in case of dystopia? Sir, like in cases if there is any trauma and if there is lateral wall fracture, sometimes people land up with lateral canthal dystopia. So, sir, how do you manage those cases?
You see, in most of the cases, you can identify the lateral canthal tendon unless until the tissue loss is there. If the tissue loss is not there, then it is a very easy procedure, same as I have shown already. You just examine properly, reoppose the all layers before going any suturing, and just see whether is there any tissue loss is there. Do retraction, do oppose, see the anatomy. In case you think that there is a skin loss is there or some lid loss is there, then different procedures are available. If less than 1/3 is there, you can then it can be opposed directly for few days, depending on the age of the patient. Young, it will take some more time. For laxity, like old age people, middle age, it take less time. For aperture problems or disfiguring little bit for some time. Otherwise we have to take graft from the ear tragus. You can take if there are a lot of things loss is there, use the upper lid conjunctiva and free graft. All these procedures can be done depending upon how much lid loss is there. Like more than 50% loss is there, then we have to composite graft we have to use different layers, because we have to replace all layers. And God has made this eyelids are so important, and every time whenever you talk to any person, you look at the eye. So disfiguring is never tolerated by anybody.
Thank you so much, sir.
Actually, you told it the canthopexy, you make it at exactly at the lateral margin.
Lateral margin slightly below. There is a little tubercle. You can say 1 to 2 millimeter below. You put the needle in such a way that it goes down.
Okay.
The needle erupts from the orbital margin, but it first passes from the tubercle.
Okay. Okay. Yeah. Right. Good.
Just a minute.
Lateral tarsus procedure is one of the very good technique, normally being employed for even for ectropion and entropion also, unless and until when you have an vertical lid laxity is not there. If you have only the horizontal lid laxity, the choice is definitely in lateral tarsus procedure. Suppose in addition to it, if you have vertical lid laxity, you can just put a simple everting suture in case of entropion.
Yes.
Yes. Thank you.